So I'm really glad that everybody made it up the extra floor and came up to listen to myself. I'm Boucher with Care Innovations, and I'll be presenting today with Monique Lambert, who Monique and I actually worked together at Intel. We're both ex-Intel folks for a long time in the digital health group. So we're both going to be presenting different technologies, different programs, different research, but kind of all coalescing towards the same point. My focus today, I'm Director for Product Development for a number of consumer platforms and Care Innovations. My focus today is really around taking solutions and bringing them to the market to solve a very specific need around caregiving. Caregiving is a huge challenge in the U.S. And it's one of those unsung things where you have literally, I could ask for a show of hands in the room of people who are actually taking care of someone in the family. Whether it's someone younger, or it's an elder parent, or a grandparent, or an aunt. Someone could be a neighbor next door where you're reaching in a couple times a week and making sure they're okay, making sure they got their meds, making sure you're a contact point for them. It's an unbelievably complex set of interactions that take place for caregivers, not only as a primary caregiver, but perhaps a secondary caregiver or a remote caregiver. And we've been looking at this for a long time, both at Intel and at Care Innovations. In fact, I had an architect on the board way back in 2004 to solve this back then, and then we kind of put it off and looked at other technologies and other needs based on resourcing, but we eventually kept getting back around to it because the problem was staring us straight in the face. And so we, over the last couple of years, have been working on a platform called Connect, and I'll talk about that. What is Connect and what does it mean, right? But for those of you who don't know, Care Innovations, we're actually made up of folks who came over from both Intel and GE, with a focus, first and foremost, on technologies and solutions and products, but we're really focused on the home health market and innovating to solve hard problems. And so we've got, we're primarily based here in California. We do have lots and lots of proven industry leadership and advocacy, as you'll see. And obviously between the two parents, I think we're the smallest large company in the world. So lots of history here. You know, Eric Dishman, who was a colleague of mine for many years, love Eric dearly. I heard he put on a pretty good show yesterday. Was it good? That's Eric. We were a founding member originally of the cast. We spent a lot of time in Ireland in the Trill research project there. Along the way, GE acquired and moved into the independent living and home health space as Intel Digital Health was doing the same. We came together as a new company funded by both parents in early 2011 and started building products both for chronic disease management and sensor networks for independent living, but also things like personal response systems, emergency response systems, our Link product line. I'm not going to spend a lot of time talking about the products and trying to advocate products here today. What I want to talk about is really a set of new capabilities we put into the market that we're trying to evolve, learn from our customer base, and try to solve a set of larger problems. So how many people have seen this kind of shift-left strategy? Okay, so we're wearing you out with that, huh? It's been around since I joined, I moved over to Intel Health in 2004. It was one of the original underpinnings of the model. I'm going to focus today here, which is in a really low cost, how do we leverage and marshal lots of resources using technology to solve problems without putting people further out into skilled nursing or assisted living or worse into highly expensive hospital care environments. So this was a drawing, literally, on a board that's been in our environment at Care Innovations for a couple of years now. And this was actually a picture we took, and then we created a chalkboard from it. But we looked at the problem and said, hey, patients are sick, they come out of the hospital, they have interactions with clinical caregivers, but that's not the only piece of the stool, right? Inevitably what happens is they're sent home, and they may go through a rehabilitation facility first, but they end up at home. And the informal caregivers, the family members, are in charge of taking care of them and bringing them along, right? Without any real substance or clinical training. You may have the resources to hire non-clinical caregiving services, home health agency services, things like that. But really what happens is the relationship and the clinical nature is here when all of the on-the-ground brick-and-mortar work after the patient leaves the hospital happens here, right? And so there are lots of companies who build technology and products to solve this need. How do I tie physicians, care nurses, specialists to a patient, right? What we haven't spent a lot of time on is once the patient actually moves past that 30-day moment, how do we bring the informal caregivers in and connect them to the fabric, connect them to the conversation, make them smarter, right? Help them help the patient, but also the care team surrounding the patient. And then how do we actually pick the right services and products and individuals to augment the care of it, right? The other thing that's interesting is caring tends to go through an asymptotic curve. So you have an event that takes place. So you've got this spike. And so you're looking for resources, you're looking for content, you're looking for help. You're trying to muster time, manage events, manage deliveries, all kinds of things, and then it kind of tailors off, right? And we find a new normal. And that time event can be 2 months, it can be 5 months, and in many cases where you're dealing with a longer term chronic condition, it's years, right? But it does find a new normal. It does find a normal. And so how do we enable services and capabilities around that? How many of you have read the caregiving Pew Caregiving report? Anybody? It's my Bible too. It's a very, hey Alex, it's a very interesting report because they started to actually segment caregiving as an activity and as a market segment about 3 years ago. And there's some really interesting data that's come out of that. So today, CMS spends about $490 billion on programs. Caregiving in and of itself, someone goes home, family members take over, that individual, that aggregate is about $480 billion worth of spending. So it's equivalent to what CMS actually puts out in programs, caregivers, informal caregivers are putting out of their pockets here. Okay? That's, there's 78 million baby boomers, you know, we've heard all the numbers, 10,000 a day, retiring. At the end of the day, there's 52 million caregivers out there that identify themselves as doing some level of caregiving to support that framework. Okay? Physically, and I can speak from this personally, my dad is 78, he has dementia, diabetes, hypertension. We just ended up putting him in a facility in Maine, but for the last 3 years, he was moving back and forth between people's homes in the family and basically wore everybody out. I mean, physically wore people out. My older brother ended up with severe hypertension as well. So caregiving does, in fact, wear people down, right? So what we need to be able to do is use technologies and tools and content and community and connectedness to build that support system so they're not quickly torn down because they are the front line, right? So the other thing that's really, really important to understand is caregiving impacts employers severely, right? So you'd say, well, Al, just build a product and take it out to the employers. Because the employers are losing people every afternoon to, I need to run and take mom to the doctor. I need to change mom's med. Mom has an event, right? So they're leaving work to go do that. And that's a huge economic impact on the employer, right? So the answer is sure, we can do that. But what we've got to solve is the larger problem and support that through the employers who want to deliver those capabilities. So, this is just kind of to equate the two programs, the informal program and the less formal program. So caregiving as a whole, it is a new normal, right? There's household tasks that you take over as a caregiver. There's meal planning. There's bills and insurance. There's personal care, both ADLs and IDLs. You end up delivering meds. My brother became a nurse, delivering injections to my dad, right? Managing medications. First thing you do is you sit down and you pull all the pill bottles together and you try to round it all up and figure out what is dad supposed to be taking and not taking, right? Coordinating services. I have people coming to the home, I need to take dad someplace, right? Dad has a specialist, dad has doctor's appointments, how do I pull all this together? Hiring and coordinating workers, right? Caregivers need respite. Transportation. Dad may or may not be able to drive. You may or may not be able to drive dad, right? So all of these are services and processes around the caregiving model. Really, how do I effectively communicate with dad's healthcare professionals? What is it I need to be telling them so that they can help him be better and instruct me so that I can be better at delivering care, okay? So, this was actually just pulled out in the last 2 years of the Pew Report, but it's fascinating. Chronic disease in people who do caregiving is up 34%. They rate their health as poor or fair, 70%. And depression doubles in people who are doing caregiving. But here's the interesting point, and one of our marketing, senior marketing folks is in the room, Nikki, and raise your hand, Nikki, so you may not do that. As we've gone out with a product to actually look at the caregiving, supporting caregivers in the marketplace, the hardest thing is to get somebody to identify themselves as a caregiver. Because they don't really self-identify. It's just what they do. Right? That's mom, I'm going to take care of mom. I'm not really a caregiver. I'm mom's daughter. Okay? And so we're getting there, right? But we have to approach caregivers in a different model, right? We have to enable them, and they have to see themselves in both the product and the equation, right? So we're learning a lot in that regard. So it's not about technology, right? Technology is easy. Frankly, we got through the whole technology thing years ago. I'm serious. I remember, we're into ACOs now, right? I remember Rios before that and Chins before that in the 90s. I mean, we solved the integrating data problem years ago. The problem is that there's a whole bunch of other factors around it. But at the end of the day, caregiving can be empowered through online tools, right? And it's not just online tools. The mHealth movement in the last couple of years is driving this connectedness, driving this data, driving this interaction model more effectively, right? So it's not about racing home to get in front of my Mac or my PC. It's, can I deliver an experience on my iPad? Can I deliver it on my tablet? Can I deliver it on my smartphone? What types of things do I want to be delivering across these devices to enable someone to be as effective as possible based on where they are? Healthcare enterprises can also engage family caregivers. We've seen this in Humana. Humana's got a great program now around caregivers. Why? Because they figured it out that this is a force multiplier for them. If I have chronic patients and I'm providing services and technologies and people to support those patients, if I train the caregivers are going to help me stay adherent, or help those patients stay adherent to my program, right? So I'm going to invest in those caregivers. What does that mean? It means I have to train them. I have to train them on all kinds of things, right? How to look for nutrition changes. How to understand what's happening in men's delivery, right? And adverse reactions. Understanding sleep patterns. All of these things that caregivers might take for granted, the enterprise healthcare enterprises are trying to formalize now to drive better data into their environment. Identifying caregivers. Caregivers are just not primary caregivers. There are lots and lots of secondary caregivers who back up the primary, right? By the way, anybody know, as a primary caregiver, what is the average amount of time someone spends a week doing caregiving as a primary?
40.
Yeah, 20, at least 20. In some cases, we've seen as high as 30. It's almost a full-time job on top of what they're already doing. Anybody know the average age of a caregiver, primary caregiver in the U.S.? In general? Yeah, it's 48 to 50, female, she's married, has a job typically, has kids, and is taking care of mom or dad or more. Okay. So how do I unburden her as much as possible, right? So there's lots and lots of things we can do around technology and platforms to enable a better experience for caregiving and really the patient. One of the things we've learned in our beta program that we've been running since the summer is we have kind of two groups of people. We have lots of people we're affectionately calling lone rangers right now, and these are people who are doing primary caregiving, but they haven't built a team around them. It's just them, right? And for whatever reason, they haven't reached out to secondary family members, neighbors, things like that. They're just running the show themselves. And so what they've asked for is, hey, I want to reach out to the community. I want to find other people like me who have my mom's similar situation or my dad's similar situation. I want to have that dialogue, right? I want to be connected. And the other thing is, I don't want to have to go find content. Bring me content. Tell me what it is I need to know, right? Based on, you know, a profile and history I have of the individual I'm caring for, individuals. So we're learning a lot about that. The other one is, you know, frankly, we do have care circles. And in our product, there's a care circle. I mean, there are a lot of products out there, Care Zone, there are all kinds of different products that have care workspaces, right? But what's really interesting is we do have a case where, you know, we have some care circles that have 2, 3 people, other ones that have 10 people, right? Depends on the family dynamic and the unit and how many people are being cared for. The other thing that's unique with what we built was we built a symmetric model. Understanding that family caregiving is not only about the person you're caring for, but about also caring for yourself. Because if you're not strong, they can't be strong, right? So we enabled a symmetric model. So if you want to take care of yourself, manage your meds, you know, maybe you're a diabetic, but you're taking care of mom and dad, you can do that in the tool, in the web application, as well as take care of mom and dad, right? And you can isolate that, it's all protected, you can control access, everything else. And we did that symmetric model in such a way that we didn't want to say, let's define you as a care recipient, you as a caregiver. Right? We're all caring for each other. Right? So what we built was a Connect Care delivery architecture. And it's a single platform. The way I want you to think about it is, how many are familiar with Salesforce.com? Okay, you go to Salesforce.com, right? You buy the baseline infrastructure underneath, and then you want a marketing collaborations package. You want this, you want that. We basically built, it's a cloud-based engine, runs in the commercial cloud, and we actually land different products and different applications on it, right? So the Connect Caregiver has actually 2 sides to it, and it's unique in that it was just cleared by the FDA to be really 2 different products. One product is commercial kind of care delivery, generic medication management, calendars, contacts, journaling, all that wonderful stuff. Inside of that same framework, I can drop in specifically FDA-cleared applications that can be connected back to clinical teams. And I isolate all of those applications in the framework, right, in the fabric. So while I'm taking medications and I'm I'm running my care protocol as a patient of a clinician team, and that data is going back to the clinician team, my measurements are also made available to me, to my family members, so that they can see that my diabetes is staying in check, I'm following my doctor's orders, I'm staying within my personal baseline, and they can help me manage adherence, right? So we're actually splitting that data off into different directions. One is clinical in nature, one is non-clinical in nature, but they essentially run on the same fabric. And this is actually the first, that I can think of, the first cloud-based application that combines both regulated and unregulated applications in the same fabric. That's been cleared for use by the FDA. So I'm going to wrap up because I want to give Monique lots of time. So I won't spend a lot of time there. I do want to say, everybody in the room, you can go try it. It's free, right? And in fact, if you sign up, it's free for a year. If you go to ciconnect.com, a great little marketing site, you can sign up right there. You'll get an email with a specific link back, and then you can go register and create your own care circle. You can build as many care circles as you want, invite as many family members as you want, try it out, bang around on it, have a ball. The other thing I want to tell people is that we're taking lots and lots of feedback, right? So it's in a very kind of beta structured form. It is a care circle, even though it's square. I apologize for that. You can basically create different circles. You can add family members or different members, clinical, non-clinical folks into the circle. There's a to-do list communication kind of bulletin board. There are individual applications, and those applications will change depending on who you select in your care circle and who you're looking at, and then kinds of interactions are happening. Mom just took her care protocol. Here's her 2 measurements. She has a medication coming up, etc. We have a doctor's appointment. There's all kinds of services and content in here too, and they're represented as tiles. So you can actually set the tiles up in any order, any direction that you'd like, based on how you want to manage yourself or manage someone you're caring for. So that's it. I'm going to jump off here.
I was originally supposed to be giving this talk, and then Martin that was actually going to cover for me. The reason why I canceled is because this was going to be shocking to you guys, but my husband died in a hiking accident when we were in France in September. I'm sorry. Take a moment. I didn't realize I was going to do that. So anyway, it took a while to regroup, and I didn't think I was really going to be able to come here and do this. But then, I think it was last week, I talked to Martin, and he told me that he was giving a talk that we just went to, and he was asked to give this talk, and then he asked me to help him give the talk, and I said, well, gosh, if we're going to help him give the talk, I might as well just do it myself. So that's the reason why I'm here, and his name is on it, even though it was my name. But anyway, that's the explanation there. And oh, by the way, one of the reasons why I tell people that, even though it's very shocking, is because I really think that there is a culture in the United States where people really don't know how to talk about death. I'm sorry.
We're glad you're here.
Thanks.
Yeah, the caregiving organization.
Don't know how to talk to somebody who has experienced loss like mine. And what I try to do is invite the conversation. And that's the reason why I just told you that. I invite people to ask me, obviously I'm not going to do it right now because I have to talk about this, but I invite people to ask me anything they want. We were, just as a little bit of information, we were actually doing a hike in Mont Blanc in the French Alps, which I later learned is one of the deadliest mountains in Europe. My husband was a mountaineer. He was an Eagle Scout. There was no reason for us to believe that he was going to fall 200 meters from a hike that day, but he did. And needless to say, that puts a whole different spin on what's important in life, which to a certain extent was the reason why I decided I wasn't going to do this talk originally. But I want to just invite you, not that you want to come up to me and necessarily ask me, but if you do, feel free to come up to me and ask me anything you want about what is it like and that sort of thing, because I really think that there's something that we need to change about the conversation that people have around this, because as a person who has experienced this, it is really easy for me to become isolated because everybody else is kind of walking around me and not really wanting to interact with me because they're afraid about me bursting out in tears like I just did in front of you and that sort of thing. So I just wanted to kind of let you know that to me, that's one of the things that came out of Sam's death, is really trying to invite people to have a different conversation about loss. All right, so and we're going to talk about successful aging. So Alan told you that we used to work together in Intel's digital health group, and I started working in Intel's digital. I've worked for Intel for 14 years. I actually have an engineering background combined with social science, and that's a whole different topic in and of itself. But I started, during my tenure at Intel, I started working in Intel's digital health group in 2005, and I worked for Eric Dishman. So part of the tradition that Eric established at Intel is this whole use of ethnography to design and implement next generation healthcare information technologies with the idea bank. Instead of starting with the technology and hoping you get the adoption and uptake and use that you assume will happen, we start with a very deep understanding, taking the time to develop a deep understanding of people, the fabric of their lives, the articulated and unarticulated needs, and bringing that back to the organization and using that as a basis for designing next generation technologies. And there are a lot of good reasons for doing that, especially in healthcare. So as of now, I've actually been doing ethnographic research in healthcare delivery, both in the US, the UK, and Asia for going on 9 years. And I have seen some stuff. And there's no wonder why healthcare is so messed up, because when you really understand it, and when you see it at the micro level, which is basically how I see it, because I spent a lot of time shadowing nurses and doctors and home health nurses, going into patients' homes and patients. So I see everything unfold moment by moment in the context of their larger ecosystem. And over the 9 years, I've really been able to understand a lot about how those forces really come together. And a lot of the very specific things that make our healthcare system the way it's currently being practiced rather dysfunctional. It's actually kind of amazing that it works as well as it does. If you understand it at the level that I have been able to observe it, it's actually kind of amazing that it works as well as it does. But there's a lot of opportunity for improvement. But one of the things that we decided to do in the David Druker Center, you heard Martin talk about our charter, was to really come up with new disruptive models of healthcare delivery. And so Paul Tang, who's the guy that runs the Innovation Center, decided, he's been influenced by Eric, so he decided that instead of the healthcare providers sitting around a table and trying to come up with what they believe to be the solutions to healthcare, that they wanted to take an ethnographic approach and really understand, not assume that we understand our patient population, but actually to go out and really spend time really understanding what is it that people are actually doing, what do they care about, what are the contextual factors in their environment, the psychosocial factors that can affect what kind of technologies, what kind of solutions even make sense. So that's what we started to do, and this is what I'm actually going to talk about. And by the way, all the photographs that I'm showing you are photographs of actual participants that we've actually, these are real people that we've actually gone out and studied. And this lady, I've got to tell you a story about this because this is something that people don't really understand or necessarily appreciate about Silicon Valley. If you go outside of Silicon Valley and you tell people that you're trying to design technologies for older adults in Silicon Valley, you don't get a lot of sympathy. Why? Because they go, you guys are just a bunch of rich folks out there, right? This lady lives in Los Altos Hills. How many people know where Los Altos Hills is? How many people know how expensive it is to live in Los Altos Hills, right? No, right? And so you look at this lady, you go, she doesn't have any problem. She lives in freaking Los Altos Hills. And so if you just look at it from the surface, you look at their socioeconomic situation and you make assumptions, but underneath all of that is quite a bit of distress and isolation and pain and struggle. And this lady actually is representative of that. So even though somebody may appear to be very sound and functional from a socioeconomic point of view, that's based on an assumption. But when you go beneath the surface and you really understand the fabric of their lives, this woman is in some ways, actually, her need may be even higher because people don't assume that she has any need because of where she lives. This woman has macular degeneration, which means that she can't drive. She lives in this huge home by herself, and oh, by the way, you see any neighbors? So this is what we talk about when we say trapped in suburbia. And she is not moving from that home. And she is not equipped to stay in that home the way it is right now. So when we talk about physical and social health risks, this woman who lives in Los Altos Hills has more physical and social health risks than people that don't have as much wealth as she has, at least in terms of land value, because of the environmental situation that she finds herself in. Does that kind of make sense? Okay, so now the talk is done. I'm just kidding. So, you know, you don't really have to spend a lot of time doing any research, just if you just think about it in terms of time. The factors that really impact long-term health and wellness of individuals, they do not reveal themselves in the context of a 15-minute visit. And oh, by the way, you're lucky if you have 15 minutes nowadays. A lot of times they're 8 minutes, and last night I was in Santa Cruz, they were talking about 2-minute visits. If you just think about it from a statistical point of view, the likelihood that factors that are really salient to outcomes are going to reveal themselves in a 15-minute visit is pretty darn small. So we already knew that looking at the clinical care delivery model was not the place to look. We've got that. You know, we know how to improve that, and there's a lot of work that needs to continue in order to improve the clinical care delivery model. But from a time point of view, from a life point of view, that's not where it happens. The factors that shape long-term health and wellness happen here, in our neighborhoods. They happen here, in our homes. And they happen here, in front of the television next to the fireplace with a food tray next to you. So when you really think about it, you don't even have to do any research. Where does your life unfold? It doesn't unfold in the clinic, it unfolds in the homes and the communities where you live. And arguably, we can make the extension and say that certainly is where it unfolds for older adults who are trying to live in community. So we realized that we actually had to go out into the community, in the homes, to really understand what is it that people are challenged with? What is it that what kind of support systems do they actually have? To what extent are those support systems really effective? And so I designed a study that little play on words here, shifts happen. And the whole idea was really to take an ethnographic approach to really understand how do seniors in the community, how did they respond to an unexpected health-related event that they experienced within the 6 months prior to when I actually went into their homes. And we weren't restrictive about what the event had to be. It could have been a new diagnosis. It could have been, they had surgery and, the lady with her leg up. So we weren't restricted on what the event had to be. In fact, we were kind of looking for a broad swath. We just wanted it to have happened within the 6 months prior. Why? I don't know how many of you have spent a whole lot of time talking to older adults, but if you go into a conversation with an older adult, open-ended conversation, I would still be there. So we needed to make sure that we had something specific that the older adult would be able to sort of recount, that I would be able to have them say, remember when you had that MI, and remember when that happened? And part of it was just to see whether or not they had how they recounted the situation, what their recollection of it was. And the other thing that we did was, after doing these home ethnographies with the older adults, at the end, I asked them, I said, was there anybody else that was participating in you responding to this event that you would feel comfortable having me talk to? And many of them said yes, and they were, like sons and daughters and that sort of thing. Some of them were other people. And then what I would do is I would go do a home ethnography with them, and I would ask them to recount their experience of that same event. So this is sort of like a critical incident method, and the whole idea is to ground the conversation in a specific event that everybody could have a perspective on. So that's really what we did there. So this study included several seniors, well actually probably about 17 seniors and about 11 caregivers in total. And that's what the data are based on. And so a few observations that emerged from the study. Martin alluded to this in the session that we came from. And this idea of closing in, another way we refer to it as sort of shrinking lines. Now, again, older adults are experiencing declines in their physical health, in their social health, in their mental health. But if you just look at it from a physical point of view, the limitations that they begin to experience in their physical health reduces the number of interactions that they are able to have, wanting to have. The thing that's exacerbated that this sort of closing in effect is it's happening to all their other friends at the same time. So it's not just, my physical limitations are limiting what I do and who I interact with, but my friends happening at the same time, and then the other friend. And so if you can imagine, all of us are little pods, and the pod is getting smaller and smaller and smaller, and we're all getting smaller at the same time, that has a compounding effect on reducing the likelihood of social interaction between older adults, because quite often they have themselves as their primary social support system. And it's a compounding effect which ultimately results in everybody kind of having this feeling that life is sort of shrinking in, that life is sort of closing in on them. So she says the piece that seniors who try to stick it out in their homes miss is the feeling of community and the loneliness factor. Because as we grow older, so do our friends. And as we aren't able to get out and drive anymore, they aren't either. So your world closes in. So this sort of shrinking lines, closing in effect. Now you might wonder, there's always a story behind all of my photos. I'm not going to go into this one, but this was actually a caregiver of a woman. She was a caregiver of her mother who had Alzheimer's. It was like a rapid onset of Alzheimer's, and she was completely caught off guard, and she had to fly across the country to kind of figure out, do I leave her there? Do I bring her back to California? It was a disaster. But then when she was recounting her story, she was sort of reflecting on her own experience as a, like the sandwich generation person. She's got her own kids, she's trying to care for her mother. And she talked about this sort of fading away thing. And she says, for so long, we're right in the circle of everything that's going on in life. And then I think as we get older, we start edging back. Now, my daughter in her early 40s with children, she's in the center of the circle, and I'm edging out of it. And I think that we fade away. So it's not just the impact of physical limitations making your life close in. It's society kind of makes you a more invisible person, especially when you retire. Because being in the workplace is a place where you are visible. It's a place where you have social relationships. It's a place where people know that you exist. When you are no longer in the workplace, you start fading away. People start not even remembering you, not reaching out to you. And you experience that. So this is more like a personal psychosocial experience of this sort of, I'm becoming diminished. Being a burden. Now, how many of us, anybody who has worked in the aging space, any of us who are caring for older adults understand this. This was a caregiver of an older adult, and I love the way he sort of described his mother's self-imposed limitations because she was trying so hard not to be a burden. And he said, what's right for mom is her to be able to do her trips and enjoy herself. Mom's attitude when you ask her is, I don't want to be a burden. I wish she'd stop thinking that. If I could change one thing about her, it would be that she doesn't see that much of her grandkids because she's often too worried that she's a burden. This part is really interesting. Her favorite place is Chantilly's. She loves to go to Chantilly's. Why? Because they treat her like family. They all know her name, and they all do everything they can to take care of her. Now, she can accept that because I think in the back of her mind, she thinks these people are paid to give service. But we aren't. We referring to the family. We're here, we're her own children, so we're not allowed to give her service. I don't want to be a burden. Damn it, Mom. That was so real. And I kept hearing this sort of, I don't want to be a burden, and not necessarily reflected this way, but the psychosocial sort of impact of seniors not wanting to be a burden and wanting to feel a sense of empowerment. They would diminish their acts of reaching out to people for no other reason than to minimize the extent to which they perceive themselves as being a burden, even on their family. And then this sort of last insight, the one that I want to share with you. This one, to me, was really interesting, and I call it micro-help. There was a lady who had surgery for throat cancer. Devastating. She even showed me the mask that they put on her so that they could hold her still when they were actually doing the surgical procedure. And I could tell by the way she talked about it that it was traumatic for her. Very independent, former professor at Stanford, I mean the whole 9 yards. She was very stoic. But then there was a moment when she got really soft in the conversation and she started talking about her neighbors, right? And this is what she said. They have no children. They're in their mid-50s. And one day, my can, the recycle can, was on the street. And the wife said, I just wanted you to know, I'll do that from now on every week. So she just gets the can, puts it on the street, and there was no talk about it. The thing that was significant to this lady, because there was no way she was going to be asking them to do that, is the fact that the lady did it proactively for her, and there was no talk about it. So this whole thing about, I don't want to be a burden, right? This action right here eliminated this trigger response on the part of the older adult about being a burden, because you can't be a burden if somebody just did it, right? And she said, I am going to do that from now on. So collectively, when you think about these very specific human insights, the challenge for us as a healthcare provider, the challenge for us as technology, innovators, how do you take those kind of very specific human insights and incorporate that into design of a health system and technology support for that health system? That is what we try to do when we take a human-centered design approach. In essence, trying to take those human insights into account become design requirements that we are trying to meet throughout design and implementation of new systems that we are developing. That is a challenge. Does that make sense, you guys? Okay. And so we use this human-centered design process, which for those of you who are familiar with human-centered design, is pretty standard. I mean, you can do some variations depending on what it is you're trying to accomplish, but you start with the observations like we just did. You talk about the stories that emerge from that, you try to aggregate those stories into themes, and then on this side, when you're trying to get into the delivery into the space, that's when you actually start talking about what are the opportunities that exist for us based on these sort of deep understandings about the challenges that people are facing trying to live independently in community. Then you develop solution concepts, like how can we actually solve that problem? and then you prototype. You want to do this rapidly, and then you actually go to implementation. So this is the whole cycle that you go through. And ethnography doesn't just start and end here. Ethnography can be used throughout this whole thing. It's just that you go from sort of like an open-ended ethnography to more applied ethnographic techniques as you go toward the implementation side. This is just an example of, in the context of what we did at Palo Alto Medical Foundation, we were doing the human-centered design. We made a decision to actually try to engage a larger organization in designing. For those of you who work in organizations, you can imagine that there are some good reasons for doing that in terms of buy-in and awareness and that sort of thing. But more importantly, we thought it was important to actually tap into the collective knowledge and expertise and experiences of all the people that actually worked in the Palo Alto Medical Foundation, ranging from people in the C-suite, physicians, nurses, staff members, patient service representatives, the whole 9 yards. So it was a very, it was a big session. It was really quite interesting to facilitate. And it was a multi-day thing as well. But the whole idea was for us to kind of get from these observations and take it all the way to these opportunities. And that's basically what this is. So an opportunity map is kind of, the whole idea behind doing human-centered design is you go from very micro-level observations, but you're always trying to move it to a higher level of abstraction, because it has to be at a higher level of abstraction for you to be able to act on it, right? Again, this is my engineering background coming in here. You need to get to a point where you actually have an actionable design path before you can actually have meaningful conversations with software engineers and hardware engineers, and you know, Alan can basically attest to all of that. So from all of that, those very detailed insights, and we spent 2 days actually going through the observations from the research, we came up with 6 opportunity areas. I'm not going to go over those right now because I'm going to review them with you very quickly, but it's nice that I would recommend not coming up with more than 6, quite frankly, because it becomes unwieldy. But one of the things that we do when we create an opportunity map is everybody who's participating in the design process gets little round sticky things. And you can give them as many as you want. I would recommend not giving them more than 3. Every person gets 3. And then you vote. You say, okay, you can put all 3 of your stickers on one area, you can distribute them any way you want, but people vote in terms of, if we had to pick the opportunity areas that we actually wanted to go after first, which one do you think we should go after first? And the reasons for going after something first can vary. It could be because we actually know how to do it, right? If we have competency to do it, in some ways you kind of want to perhaps elevate that as opposed to an area where you don't even have competency, because then you have to do all this other work just to kind of get it. If that's the simplest thing for us to do, that could be another reason. So you have to be clear about how you're actually sort of driving the priorities, or how you want people to think about the priorities. But at the end of the day, you've just got a bunch of things, you've got a bunch of votes, and then you say, okay, do we all agree that this is the one that we should go after? And for the most part, people say, yeah. And it turned out in our particular situation, the value economy is the one that got the most votes. And the whole idea behind the value economy is this idea that in a volunteer culture, which is kind of representative of the United States, we talk a lot about volunteering. But one of the limitations of volunteering, as good as it is it's still a one-way street. There's a person who has resources, the volunteer, who is providing help, assistance to a person who is perceived or actually does not have resources. That's the recipient. And as much as that's a great thing, it still creates a power differential and asymmetry. And it doesn't address, remember, that one requirement about fading away, right? It doesn't address the requirement that one of the big things, and also not being a burden, one of the big things that seniors experience from a psychosocial point of view is they need to feel in a sense of continued value and purpose. And by being the recipient of help, although that might satisfy a lot of their needs, we're losing an opportunity for them to actually provide value back to somebody else who may not actually be the person who's giving them the help in the first place. So this whole idea is, how do we actually create a value economy where seniors are discoverable, they're visible, and their status is elevated in terms of the value that they can provide to other people, not just the value that they can receive from other people. And when you think about it intuitively, if you've been around this world for 70, 80 years, you kind of know some stuff, right? And so why do we just automatically assume that they don't really know anything, they don't really have anything to offer? And arguably what we're trying to do with our approach is we're trying to create a platform where we can make what they know, what they can do, what they've harnessed over the last 40 years discoverable to the rest of the community. And so these are the 4 components that we've developed for the linkages system. There's a personal profile, signal detection, resource matching, and micro communities. And then just real quickly, the whole idea behind the personal profile is, again, this is not rocket science. When you go to a doctor, the doctor basically knows information about you from a medical point of view. They know your disease state, they know what medications you're on, but they don't know things necessarily like, do you live in a 1- or 2-story home? Which is kind of a no-brainer if you're talking about older adults. Do you drive? Do you have a caregiver who drives? Does that caregiver work? So there's all this contextual information that healthcare providers just don't have. But guess what? If they don't have that information, they cannot be making the best treatment decisions, right? Think about it from a physical therapy point of view. If you can't drive, and I'm a healthcare provider, and you need rehab, and I give you an order so you can go to some physical therapy place that's 2 cities over, guess what? What is the likelihood that you're actually going to be adhering to that order? It goes way down. Do you think seniors are going to say, oh, sorry, doctor, but I don't drive? Seniors don't want to be a problem. They think doctors don't have enough time, so they don't necessarily make a fuss, right? So by having this more contextual information, we're hoping that we can provide just the right information to healthcare providers, physicians specifically, because you cannot overwhelm them with too much information because they won't use it. You provide them with just enough information such that it can contextualize their treatment to increase adherence. That's one of the things that we're doing. The other thing that we're trying to do with the personal profile is to say, and Alan brought this up, this whole idea of, you can't expect seniors to go out foraging, but if we can collect information from you in the context, it's kind of like a little mini survey, and you hit the button, and then when you hit the button, the system will actually query all of the other resources that exist within the system and bring it back to you and say, based on your answers to these questions, we think these resources, they could be human resources, they could be other types of resources, community organizations. These resources are relevant to your situation. You don't make them do anything, but you see whether or not they pursue, they look for more information, because at that point, from a system point of view, then you get a little bit more reinforcement that, okay, this one is more interesting to them but because they actually took an action to look for more information. So that's the whole idea behind the profile. Signal detection, we've talked about this. This one is actually pretty well discussed in the context of this conference, this whole idea that how do we use technology, sensors largely, to proactively detect and mitigate changes in a senior's physical or social health status. We're looking at it from 3 points of view. The physiologic monitoring is the one that we often hear about. But we're also looking at this notion of okayness checking, which is something that some companies are pursuing, this whole idea that a caregiver, not a clinician, would be able to do sort of remote okayness checking on you by having sensors in the home. Like, did mom actually go to the bathroom more than she usually does last night? And those can be red flags for a caregiver that understands routines. When the caregiver begins to see deviations from a routine, because the routine is really the only thing that you need to monitor. You don't have to monitor everything, because caregivers know a very well-established routine. They know what they are. And then when the senior starts deviating from those routines, that's when you get concerned. So that's what we're trying to monitor. And then the third thing here is this notion called participatory sensing, is social sensing. A lot of people live around seniors, but they don't know them. But they see their patterns. They can see whether or not the newspapers are accumulating in the driveway. They can see whether or not the blinds are drawn or not. But they start getting concerned, but they go, oh gosh, I can't invade their privacy, I'm not gonna do anything. What if we created a system where people that are in the neighborhood, because you're neighbors, even if you don't know the person, somehow there's a social system for you to be able to say, something doesn't look right. Take a picture of the newspapers accumulating in a driveway. And there's a place for that information to go, and there's a way for the senior to actually acknowledge that it's okay for you to watch out for me that way. That's the okayness checking. I mean, that's the social sensing system that we're talking about. And I'm gonna wrap up here really quick. Resource matching, this one is the obvious one. Seniors are constant, I mean, look at all this. We're talking about durable medical equipment up the wazoo. And they don't even know what they don't know in terms of what they need, what are the attributes of that technology. There's a lot of stuff that seniors and caregivers need, and they're constantly spending time trying to find it. But one of the big problems in healthcare is the resource finder. How many of you know about the resource finder? Right. It's usually a physical binder. You got pieces of paper in it. You got the names of all these organizations and maybe some other information. How much work does it take to keep that up to date? Right. Okay, so we said, you know what? Good resource, bad implementation. How do we rethink this? And we said, what about Yelp? Right? So what is the source of information in Yelp? The source of information in Yelp are other people who have actually experienced that resource. So we're thinking in terms of resource matching, how do we actually leverage the collective experience of people that live in the community to create a community database of resources instead of some person or some intern sitting around and spending months calling up these organizations to figure out whether or not they're still in business, which, by the way, even if you do that, that doesn't give seniors and caregivers the contextual information that they need to decide whether or not that's even an appropriate resource for them. But how many of you have gone on Yelp and you said, wow, I'm in downtown San Francisco, I'd like to try a new restaurant, but I have no clue. You go on Yelp, you look at the reviews, you're like, wow, gosh, they talked about that, miso marinated sea bass, that sounds great. And that was enough for you to decide to actually go check that resource out. One piece of information, that piece of context was enough for you to make a decision. And we think that other people who have had experiences with all kinds of resources, not just community organizations, but restaurants, hairdressers, parks, but you provide that review from the perspective of an older adult or a caregiver of an older adult, that will be an actionable resource that everybody in the community, not just older adults or caregivers, would be able to use in order to facilitate the discovery of these resources in the community. And then last but not least is this whole notion of time banking. It seemed like people were really interested in this whole time banking concept, and that is the first component of the linkages system that we've deployed. And I can tell you everything there is to know about time banking because I was the person that really advocated that we do this. But time banking is specifically a community-based service exchange network where members provide neighborly services, and I emphasize neighborly services. It's not TaskRabbit. It's neighborly services to one another in exchange for time. And the time banking concept was also very central to this idea of this value economy. How do you create a senior value economy? How do you actually make seniors feel like they can receive and give services with other people in the community without feeling like they're being a burden or there's an asymmetry in the relationship between those people? A time bank is a pay-it-forward system. It's not a barter system. And we specifically chose time banking because it had that attribute. So I want to end here. There's more, obviously, that I can talk about. But I just wanted to kind of give you a little bit of an introduction to the motivation for the linkages system, that it's a platform that we put together. The whole idea is not for us to do it for the community. The whole idea is for us to give these tools to the community so that they can do it for themselves. Because what we found is that we don't have to create any new resources. The resources already exist, but we can't discover them. We don't even know where they are. So our platform is really designed to actually enable the discoverability of these resources and then the connectivity between these resources so that people can do for themselves what they're not able to do right now, fundamentally because the discoverability of these resources is completely hindered.